All right, so thank you for having us here today. We certainly appreciate the opportunity to speak. We will try and keep this brief, as I understand that I'm standing between you and lunch. So we've got 10 minutes slated, and we'll try and keep it under that 10 minutes. So what we wanted to show you today was just some of the things that we're working on in terms of some new real-time feedback. You've seen the last couple of presenters talk about real-time CPR feedback. And so what other problems can we solve, or what other areas can we offer guidance to providers on scene to make better clinical decisions and offer better clinical care? So just a basic question, right? We talk about ventilating a patient with a bag valve mask or a resuscitator bag. Pretty easy, right? Pretty straightforward. We all do an outstanding job of ventilating at normal, acceptable volumes and normal, acceptable rates, correct? Yes? Now, if you look at the study data out there, the rates and volumes are all over the board. In healthcare, and this is not just EMS, in healthcare, if you hand somebody a bag, a resuscitator bag, or a BVM, we don't ventilate patients, we overventilate patients. Inherently, you wind up squeezing that bag 20, 30, 40 times a minute. Some of the study data shows 37 as an average for ventilation rates when you hand somebody a BVM. The other side of that is how much inspiratory volume does your patient need? Right? We hand you, as a provider, a bag that's somewhere in the neighborhood of 15 to 1,600 mLs and ask you to ventilate a patient and do your best. Ventilate to chest rise, just squeeze with your thumb and 2 fingers. There's all different sorts of guidance out there. But in all reality, how much volume does your patient need? And if we look at the critical care setting, it's pretty well defined, right? It's weight-based based on a patient ideal body weight, somewhere between 4 and 8 mLs per kilo based on ideal body weight. But in terms of EMS, we don't necessarily see those numbers being adhered to. When we talk to EMS providers, a lot of EMS providers have no idea that there is a weight-based volume that should be delivered to patients. So some other challenges with bag valve mask ventilation, we lack feedback on tidal volumes, we lack feedback on ventilatory rates, gastric insufflation volumes, airway pressures, leaks. And one of the things that has come out recently, and I'm sure it's a concept that people have understood for years, is the rapidly refilling bags are actually doing us a disservice as clinicians. Basically, a lot of clinicians feel that as soon as that bag is full, it's time to squeeze it again. And it takes about a second for that bag to refill. It actually takes longer for us to deliver a breath than it takes that bag to refill. And it's just this vicious cycle that we get into. So there is some work being done on these slower refilling bags, trying to control rates when we are ventilating patients. So this was a study that came out in 2016. So we've looked at a couple of different healthcare segments. So physicians, nurses, first aid workers. We did not include EMS, or EMS workers were not included in here, although they typically fall somewhere right around, somewhere between physicians and nurses in terms of how they ventilate. So excessive ventilation for physicians, 72.2% of the time, nurses 74.4%, and first aid workers 90% of the time. So again, we typically don't ventilate patients in healthcare, we overventilate them. So some clinical effects of poor ventilation, the effects of increased ventilation rate or tidal volume. We see increases in mean endothoracic pressure, we see increases in lung volume, and we see increases in pulmonary vascular resistance, which has a direct relationship on cardiac output, right? We see reductions in venous return to the heart, cardiac output, coronary perfusion pressure, and aortic blood pressure. So overventilating these patients causes some substantial hemodynamic effects. Excessive ventilation also favors gastric insufflation and subsequently pulmonary aspiration as well. So there's a whole host of issues that occur when we overventilate these patients. So, as you saw with the last couple of presenters, we have seen what we can do with real-time feedback in cardiac arrest, real-time CPR feedback in cardiac arrest in terms of getting to appropriate rates, getting to appropriate depths, increasing chest compression fractions, all of that. And I think probably the best set of data that we have on that came out of Arizona in the US. So this was a study by Dr. Ben Barbaro and Tyler Vaudebancourt, who showed that it was a blinded study, so initially collected data for about 16 months with zero feedback, just data collection, and then we added feedback and training, and you can see some of the numbers. So before feedback, average compression rate 128 per minute. After, average was 106 per minute. Before, average depth 1.78 inches. After, 2.15. Pre-shock pauses 26.9 seconds prior to implementation of feedback. After, 15.5. Certainly, we've shown with the last two presenters that we can certainly do better than 15.5 seconds for pre-shock pause. But overall, CPR fraction, 66% to 83.7%. So dramatic improvements. And so what does that mean for survival? So all patients changed with CPR feedback. There was an increase of 59.7%. So adjusted odds ratio, 2.72. So you're 2.72 times more likely to survive cardiac arrest if CPR feedback was used during your resuscitation. And the most compelling piece of information, the witness shockable rhythm. These are patients that should be resuscitated, right? The ones that should be the easiest patients to resuscitate, the ones that are most viable. And there was an increase of 113.8% in survival. So based on that, we thought, well, if we could do that with chest compressions, what can we do with ventilation? So we're bringing a technology to market. And for any of you who have a chance, if you want to stop by the Zoll table later today, Charmaine will have a device with Accuvent and real BVM help. So basically, it is a cable, reusable cable, single patient use sensor that connects into the airway. It connects into the side of the device using a port that is already on the device. And attaching that is going to get you this dashboard. It takes a single breath to initiate the dashboard. As you start to ventilate, that dashboard appears, and if you look, you've got target volume, target rate, delivered volume, delivered rate, and then a countdown timer in the middle that is going to ideally time the provider to deliver that appropriate rate. So real-time depth and rate or volume and rate feedback on the screen, breath to breath. So we talked a little bit about the parameters on there. That's what the dashboard looks like up close. So you'll see up top, you've got from left to right, target volume. That's adjustable. It's configurable in the menu, so we can have a default volume, but then the provider can change it on scene. So for those different patient populations, the provider has the ability to change that. And then the feedback is based on the target volume. So if you're plus or minus 50 mLs to the target volume, you'll have green numerical values. If you're outside of that range, you'll see yellow numerical values, which should prompt the provider to make some minor adjustments. Same thing with rate. We can set a default rate, but the provider has the option to change that. And then guidance will be based on your target rate. And then the ventilation quality indicator in the middle, that's your countdown timer. But if your two numerical values are green, that will be green, again, showing you that both depth and rate are in target, and that is a quality ventilation that you're delivering. This is compatible with our CPR feedback. So again, once you start compressing using our CPR pads, the CPR dashboard will come up, and it will coexist with our real BVM help dashboard. So that's what it will look like at the bottom of the screen. That takes up the bottom channel, and they do coexist, and the color schema is pretty much identical. Again, in range, green numerical values, outside of range, yellow numerical values. So it should be very easy for the provider to understand. It's a very consistent display. So in terms of testing, we did some basic testing in the lab. 20 EMTs worked in pairs, performed 2 simulated resuscitations, so 8 minutes broken down into 2-minute cycles. 2 minutes of CPR while a provider ventilated for 2 minutes, and then they swapped. The first scenario was chest compression, ventilation feedback was disabled, just measured. Then we did some training, went back, turned all the feedback on, and then reassessed. So just to give you an idea of what the improvements were, so without feedback, compression in target for rate, 36%. With feedback, compressions in target for rate, 76%. Compression target for depth, 34% to 70% post-feedback. Depth and rate, 16% to 55%. And then in terms of ventilation, ventilations for target in rate, 41% after we turned feedback on, 71%. Ventilations in target for volume, 31% after we turned the feedback on, 79%. And ventilations in target for rate and volume combined, initially 10%, and that improved to 63%. So we saw a dramatic improvement in just a very controlled lab environment. So if this was what we were able to do with no outside distraction, where they could focus on ventilation prior to that feedback being turned on, when there are all these different stimulus on scene, what kind of impact would we have providing this type of feedback to the providers? So compatible airways, it's basically compatible with all airways. Compatible with bag valve masks, or resuscitator bags, any of your supraglottic airways, your iGels, LMAs, King tubes, endotracheal tubes, trach tubes, as well as the swivel adapters or extensions. So completely compatible with all of these end-tidal CO2 adapters, rescue pods, all heat moisture exchangers, moisture filters, you name it, it's compatible with those. So that's about all I have for you. Do you have any questions? Again, if you'd like to see it in person, just stop by and Charmaine would be happy to show it to you. So if there are no questions, thank you very much. Appreciate your time.